And thank you for joining me. So as we discussed, I'm going to be going over gynecologic symptoms that sometimes women might be tempted to ignore, either because they don't want to bother talking about them or they don't seem so bothersome, but these are all things that really should be addressed. So first, I just want to introduce myself. I myself am actually new to the Boulder area as of December of 2020. And given the current state of the world with the pandemic, haven't had huge opportunity yet to get out in the community and meet everybody. So I'm happy to be here tonight, even if it is virtually, to say hi and let you know that I'm here to serve the women of Boulder. I originally am from Michigan. That's where I did all my training. I went to Michigan State University, go green, for both my undergraduate and my doctorate. I did have a short stint at University of Michigan, our rivalry school for a master's in public health, but bleed green through and through. So I spent most of my life in Michigan. I did a brief stint in Florida where I discovered after just a year that I was meant to be in 4 seasons, and then I discovered this beautiful area and moved here. So I'm happy to be here with my 2 little pups. We love to go out and explore the area and look forward to serving the community here. So I have had an interest in robotics really since my residency. The robot was just coming out when I was in training, so I was actually involved with developing the curriculum for residents to get trained with the robot and have been working with it throughout my whole career. Love to see how well women do after those types of minimally invasive procedures, and we'll be sharing some of that with you today. And then also just wanted to say I have no financial disclosures. I don't work for any outside companies or receive any financial compensation from anybody else. So first, just a brief outline of things I'll be talking about today. We'll go over 10 symptoms. A lot of these could arguably be an entire lecture in and of themselves, but we'll try to get an overview of each of them. So in the beginning, we'll kind of talk a lot about bleeding and different variations of periods and how they can cause issues, and then we'll get into different kinds of lesions and other things that we shouldn't be ignoring. And I did notice that we lost number 6 on this slide, but we'll leave that as a surprise for you to find out what that's going to be, and then you'll know we're halfway through at that point. So to start off, I think if you asked any gynecologist, the number 1 symptom that women should never ignore when it comes to bleeding, it's going to be postmenopausal bleeding. So menopause, first of all, is defined as a full year of no periods. Some women will find that their periods gradually spread out. It can be hard to remember exactly when your last period was, but when you're getting to that phase of life, I'm usually talking to you at your annuals about noting down when your last period was so you can get to the point where when you look back, you'll be able to remember. But basically, anytime after you've had a full year of no bleeding, we wouldn't expect you to have bleeding ever again. And if you do, it should always be evaluated. Even if you think you might know why, or you think something happened that explained it, always want to bring up postmenopausal bleeding with your doctor. There can be many causes for this, which, as you can see, I outlined here. But the reason that we never want to ignore it is because postmenopausal bleeding can be an early warning sign of a very significant issue of endometrial or uterine cancer. The good thing is that this particular cancer does come with an early warning sign, and that's why we always want to know if there is bleeding after menopause so that we can do a proper evaluation and rule it out. But that being said, you don't have to fear immediately if you are having bleeding after menopause that it is cancer. There are certainly many other causes which I've outlined here, such as precancerous cells, vaginal atrophy, infections, hormone replacement therapy, fibroids, other diseases or different medications that you can be taking that could also be causing the bleeding. So really what we need to do is evaluate it. So how do we do that? First of all, getting a good history, talking to you, finding out when the bleeding happened, if it's still happening, how much, how often, and then doing an exam. Really doing a thorough exam can kind of help us as your physician narrow down what might be going on. We might want to order some laboratory tests. The FSH is a hormone level that can tell us if you're menopausal or not. As I mentioned, some women, their periods spread out, and you might think it's been a year, but has it been a year? I'm not really sure. If we're questioning if you are in fact menopausal or not, we can check that hormone level and see if it shows that you're menopausal. We can also check your estrogen progesterone levels if you are taking hormone replacement therapy. If we're thinking infection might be the cause, we can do a vaginal culture. But the most important thing with postmenopausal bleeding is also getting some imaging done. As I mentioned, what we're really trying to rule out is making sure that there's no sign of abnormal cells, like precancerous or cancerous cells, inside the uterus causing that bleeding. So what we want to do is get a pelvic ultrasound, which, as a physician, what we're looking at is the size of your uterine lining, which is called the endometrial stripe. If you read any textbook, it's going to tell you that that lining should be less than 4 millimeters in a postmenopausal patient. So if we get this imaging and that magic number is higher than 4, you're going to be told that we need to do a further evaluation to take a look at what those cells are inside the uterus. And that's something we call a biopsy of the uterine lining or the endometrium. This can be done in different ways. There's an in-office endometrial biopsy, which is done with this little straw-like device that I put on here, which basically is inserted through the cervix and into the uterus. We pull back on the straw and some cells will come out with it, and we can send this to the pathologist to look at under the microscope and examine the cells to see if they look like normal uterine tissue. Sometimes this procedure can be difficult to do in the office if the cervix doesn't want to open enough to let the straw go through, or it can be very uncomfortable for some women for various reasons. And so we can also do this evaluation in the OR, which is called a DNC, or a dilation and curettage, which can be done for many reasons, but in the instance of postmenopausal bleeding, we're looking, again, to evaluate that uterine lining and make sure that there's no precancerous or cancerous cells in there. So of course, treatment is going to be very varied based on what could be going on. Again, if we do identify cancerous cells, then we're going to recommend that you see a gynecologic oncologist. Like I said, postmenopausal bleeding can be a very early warning sign for uterine cancer. So the good news is that oftentimes we catch it early, and it can be easily treated and even cured with surgical and potentially some medical management. Precancerous cells, which the medical term for is hyperplasia, can be treated a lot of times medically with a progesterone therapy, such as the Mirena IUD or oral progesterone therapy. If it's a case of the bleeding actually not coming from the uterus, but coming from the vagina, or the vaginal atrophy that I was referring to, this is also common in postmenopausal women because the vaginal tissues are simply very sensitive to your hormone estrogen. And once those levels drop, as they do in menopause, this tissue can become much less elastic, loses a lot of collagen, can be very easily irritated, even just from walking around day to day, and of course, other activities like intercourse can further irritate the tissues. So that can be treated with vaginal estrogen therapy, giving you some estrogen back directly to those tissues with a cream or different suppositories. There's also newer vaginal laser therapies that are available. Most of these are basically CO2 lasers that dermatologists have used for years on the face and in different areas, and we have now seen that using them on the vaginal tissues can also increase collagen production and improve the health and elasticity of the mucosa and relieve some of these issues. Some of the lasers you might have heard of would be like Mona Lisa Touch, or the Diva laser are all options for atrophy, even beyond medical therapy that we now have. And then, of course, if there is some kind of infection present, we're going to treat the specific infection. Sometimes it can be determined that the bleeding was due to your hormone replacement therapy dosing, and so we might need to work on your dosages of either estrogen or progesterone. Sometimes fibroids are found, which I'll dig into a little bit deeper in some of the other slides. And then, of course, if there was a disease in an adjacent organ, we tackle that. Some women, when they're newly put on anticoagulation therapy for various reasons, like other medical problems like atrial fibrillation or blood clots, can also have new onset vaginal bleeding just with the blood thinners, and sometimes we need to adjust that dosing also. So the next bleeding issue we'll talk about is when you're having more than one period a month. This is one that women generally do come in and talk to us about, because who wants that? The normal cycle is defined as occurring every 28 days plus or minus 7 days. So some women do have a slightly shorter cycle with a period every 21 days, whereas some women it can be extended longer. But if you're having anything more frequent than every 21 days, that would be considered a frequent period. And that would be something you should come and talk to us about. So there can be many causes, again, for this. It can be from external sources. Women can respond differently to different hormonal contraceptions, and they can cause various issues with bleeding. Again, hormone replacement therapy. Other hormonal imbalances beyond our female hormones, like thyroid disease, can also cause issues with the menstrual cycle. There can be actual structural issues that are adding to surface area that you can bleed from, and therefore causing more frequent bleeding. Pregnancy could present as a bleed at a time you didn't expect it. And certainly other systemic diseases like liver disease or clotting issues can cause more frequent periods. And then it can also just be age-related. Both young adolescent women who sometimes have first started their period can have a hormonal axis that just hasn't quite matured yet, so it's not quite regulating periods like we would hope. And also women who are in that perimenopausal phase who haven't reached that full year of no periods yet. Their hormones might just be still at a level that they're producing a cycle, but not working to regulate it quite as closely as we would normally expect, so they can be having some frequent periods also. So again, how are we going to evaluate this? You'll get used to me saying this. First, we're gonna do a full history, talk to you about how long this has been going on, what your periods exactly are doing. Doing an exam can help us look for any structural causes or things that we see on exam immediately that we know could be causing some more frequent bleeding. Certainly doing some labs can help us evaluate further. Like I mentioned, your thyroid function, so doing a TSH to see if your thyroid is out of balance, that could be impacting your menstrual cycles. Checking your blood counts to make sure if you really are having frequent periods that you're not becoming anemic. If we think an infection is a source, we can do a vaginal culture. But again, here we are with the imaging. It's a good idea when periods are frequent to have a pelvic ultrasound done. That's really gonna help us evaluate for those structural causes, things that could be physically inside the uterus that are leading to extra bleeding for you. And sometimes pelvic ultrasound can give us an idea of what's going on, but we might need a little bit better characterization, and we can also do pelvic MRIs if ultrasounds aren't giving us a clear answer. Sometimes, in these cases of frequent bleeding, we might also want to evaluate that uterine lining, even in the case of a woman who we expect to be menstruating, so not postmenopausal yet, but having frequent bleeding. We might wonder if some of the cells inside the uterus are abnormal, and we could also do the biopsy, as I had mentioned in the last slides, to evaluate this condition also. So again, treatment is really going to vary based on what we find in the evaluation or suspect could be the cause. So if there's some external source, for example, if we suspect that your particular type of hormonal contraception is causing frequent periods, we might recommend changing the method. For example, Nexplanon, which is the implant that goes in a woman's arm, is known to cause irregular periods, which can be quite frequent for some women. If that's been the only change in your recent history, we might suggest that we try something else. If your hormone replacement therapy dose has changed, we might suggest changing that dosage. If we do evaluate your thyroid and that is showing to be not quite where we want it, that can certainly throw off your cycle, so then we'd recommend that you get that treated and see if that takes care of your frequent periods. Again, of course, if we find you're pregnant, then we'll go down that road. If we think there are other systemic causes going on, treating those first would be the recommendation before just looking at the bleeding and treating the bleeding alone. For adolescents, like I was mentioning, sometimes if it is becoming very bothersome and interfering with their daily lives or going to school, we can do medical therapy to help regulate cycles with hormonal contraception. And the same with perimenopausal patients. That should have been right there. I was going to delve a little bit more deeply, though, with this topic into those structural abnormalities I was talking about that we could potentially find on ultrasound. So first of all, uterine polyps are basically an outpouching or growth of extrauterine tissue inside the uterine cavity that basically results in extra surface area that you can bleed from. Women typically notice symptoms of these with either having frequent periods or heavier periods, or bleeding in between their periods. So that is usually our cue to go ahead and do an ultrasound. And a lot of times we'll notice these on ultrasound when that inside lining of your uterus appears to be thickened. You can also have a polyp right at your cervix. So a lot of times that's what when we're doing an exam, we can see that right on our exam, that you might have a little bit of an extra amount of tissue growing out of the cervix, which is most typically benign endocervical tissue, but it's an extra, again, surface area for you to bleed from. So that's something that can be easily taken care of with removal in the office. And then the ultrasound, of course, can also identify fibroids, which are benign, smooth muscle tumors of the uterus. So people typically get worried when they hear about those, but there's actually lots of things that we can do about that. So first of all, to go back to the uterine polyps real quick, those are a quick removal surgically with a minimally invasive hysteroscopic surgery. So a hysteroscope is the fancy medical term for a tiny camera that goes through the cervix and up into the uterus. So there's no incisions with this surgery. It's all done vaginally. We can actually look inside with the camera and see with our own eye exactly where your polyp is, and we can insert instruments through that camera to actually grab the polyp while we're watching and take it out. And a lot of times this will take care of bleeding in between cycles or frequent heavier periods because it gets rid of that extra tissue. Like I mentioned, the cervical polyp can be removed right there in the office, right when we see it on exam. The cervix and uterus don't have pain receptors like you would expect. For example, when you get a shot in your arm and it feels sharp or painful, the cervix and uterus just feel pain as cramping, similar to if you had a crampy period. So while it sounds like something that might not be at the top of your list to get done, having a cervical polyp removed in the office can be rather quick and really just be a little bit of cramping and a quick twisting motion, that polyp is gone. And then of course we can send it to pathology to look at under the microscope, make sure it's all normal tissue. And a lot of times if that is what we found on exam, that will take care of your issue. Fibroids can have a full range of treatment, from medical therapies with hormone management. So sometimes we find fibroids that are actually quite small, only 1 or 2 centimeters in size. So they might only be the size of your pinky finger. And with those, or for patients who aren't excited or wanting to have a surgical procedure done, and the issue is you're having frequent periods, then we can use a hormonal contraception to kind of regulate your bleeding a little bit better and take away some of the effect of that fibroid. There's a procedure called a uterine fibroid embolization, which is actually done in the radiology department through interventional radiology, where they can go and through your femoral artery, actually try to locate the exact location of the arteries that are feeding your fibroids and plug those arteries off so that the fibroids can't get any more blood supply and therefore can stop growing. So that's another option for more conservative management. And then when you get into surgical management of fibroids, a lot of times we're talking about myomectomy or hysterectomy. So a myomectomy is a procedure to remove the fibroid and the fibroid only. This is a surgery that we typically do because we're trying to preserve a woman's uterus because she's young or desires to have future childbearing. Now, that being said, dependent on the extent of the surgery, having a myomectomy can certainly impact future pregnancies. Depending on the size of the fibroid and where it lies specifically in your uterus, if we do have to go into the cavity of the uterus at all in order to remove the fibroid, then that would mean that if you had a future pregnancy, you would have to deliver by cesarean section because your uterus would be considered at a very high risk for rupture due to the history of having a prior extensive surgery on the uterus. But myomectomy, ultimately, the benefit, again, is to leave anatomy intact, and you can still have future childbearing. And also the scope of myomectomy really does depend on where your fibroid is, how many there are, and how large they are. So some women can get fibroids that are actually just within the cavity of their uterus. And with this, we can actually do a hysteroscopic myomectomy. So similar to the uterine polyp procedure I was talking about, this is done vaginally. There's no incisions. We insert a camera into the uterus and can actually see the fibroid and have different instruments that help us remove the fibroid from inside the cavity without having to make any incisions. Sometimes for large fibroid uteruses or multiple fibroids in the uterus, it is recommended to have an open abdominal procedure, which is kind of what's depicted in this picture here, where you have an incision to what many women think of similar to a C-section across your belly. We open everything up, take out as many fibroids as we can, sew the uterus back together, put you back together like we found you, and then you do have a recovery that is significant given it is an open abdominal procedure, so you'll be in the hospital for a few days, and full recovery is usually up to about 6 weeks, and then if you were trying to conceive, we, depending on the extent of the surgery, talk to you about specifically how long you have to wait. But there is also sometimes the option for a minimally invasive myomectomy. Again, if your fibroids are small enough or in locations that are easier to reach, we can sometimes avoid having to make the large incision and instead do the smaller, more laparoscopic type incisions, which are usually at your belly button and then one on either side of your abdomen, and try to remove your fibroids that way and get you a little bit quicker recovery. When myomectomy is not possible or a woman doesn't desire her uterus for future childbearing, then a lot of times we do talk about hysterectomy. So hysterectomy specifically refers to only the removal of the uterus and cervix. That's usually actually one of the most common questions I get is, how is my hysterectomy going to impact my menopausal status? And if your hysterectomy is done before you are menopausal, so meaning you're still having periods when we're talking about this, which in this case, we would be talking about how you're having heavy periods, it would be recommended to actually leave your ovaries in place as long as there were no concerns with the ovaries, of course, on ultrasounds or any abnormalities that we knew about. We leave the ovaries so that we don't cause early menopause with a hysterectomy if it's done before natural menopause. So it really won't impact your menopausal status, and you'll still be getting your hormones from your ovaries, and you'll get all those benefits of having estrogen from your ovaries. But hysterectomy, just like myomectomy, can be done through various different methods. There's the open abdominal hysterectomy, which I think is kind of what's commonly thought of, and really the hysterectomy of years ago that some women are very worried about and concerned about having to deal with that recovery. This nowadays is typically preserved for when it's only necessary for very large uteruses. So something that we're not going to be able to remove through a smaller incision, something that we don't want to cut up into smaller pieces to have to remove. So this would be an incision, again, similar to a C-section a lot of the times, that you would then be in the hospital for a couple days recovering from. There is a vaginal hysterectomy, which is done all through the vagina. There are no incisions with this other than vaginally, so no abdominal incisions. It is a little bit of a blind procedure. If you can imagine, we're going in through the vagina, so we can't see into the abdomen until we already get in there. So some of the first incisions, we have to depend a lot on our feel and anatomy being textbook anatomy and following the book. So some consider this a blind procedure, and for women who've had other surgeries inside their abdomen, this could be considered a little bit more risky if there's concern that there could be scar tissue or anatomy just not exactly where we expect it, because we can't necessarily see right away when we're entering. And then you get into your minimally invasive options, which would be laparoscopic or robotic hysterectomy. So the main difference between the laparoscopy and robotic surgeries is really the instruments that are at the surgeon's disposal. So with both procedures, you're going to have smaller incisions, kind of as I outlined here at the top. This is the type of incision that you would be expecting for an open abdominal hysterectomy, whereas your laparoscopic incisions are going to be these smaller, really 3 to 8 millimeter incisions, probably not this many all at once, but some formulation of a combination of these, usually 3 to 4 for a procedure. And then your anatomy will be taken out through the vagina, so you will have a larger incision up inside the vagina that does have to heal longer. But the laparoscope, with the instruments that we have, are what surgeons kind of refer to as straight stick. So they are literally sticks that go in those tiny incisions, and they can move up and down and side to side, but they can't bend at all. Why we got so excited when the robot came along is because it really gives us a lot more dexterity. We can actually articulate our wrists, and the instruments inside are doing the same thing, which means that we're able to do a lot finer dissections. And for patients who have perhaps had more surgeries or might have more scar tissue or challenging anatomy inside, we can do a lot finer dissection more safely with the robotic instruments. So we also find that because we can move the instruments inside the abdomen more, we're not having to move them at the site of your abdominal incision as much. And so that's why patients a lot of times might feel that their recovery is a little bit smoother, or they feel a little bit better faster using the robotic procedure. So it really, again, kind of depends on your anatomy, and of course talking to your doctor and what you both think will be best for you, but minimally invasive surgery is certainly a great option and can result in a hysterectomy that, while it is a major surgery, is not necessarily gonna lay you up for months at a time. So we just talked about having frequent periods. Now let's talk about having heavy periods. So we talked about how long the normal cycle should be, but the average blood loss should be about 20 to 60 milliliters. So heavy periods can be defined in either two ways. They can either be prolonged, meaning that they last for more than 7 days. So when your period comes on, we don't expect your bleeding, even if it is spotting in the beginning and end, to last any more than 7 days. And we wouldn't expect your blood loss to be any more than 80 milliliters. Now, who is measuring how much blood they're losing? Not many women. So how do you estimate that? It can be hard to do. Some women, if you're using a menstrual cup, the menstrual cups, a lot of them do have actual measurement markers on there. So for the menstrual cup, you might actually know how much you're losing. If you're using tampons, a regular tampon can hold about 5 millimeters or milliliters of blood, and a super tampon about 10. So if you kind of calculate out, you might figure out roughly how much you're using. Even those measurements, though, can be off because, admittedly, with our period, it's not solely blood flow. Sometimes, it's actually the uterine lining shedding, so there might be some actual uterine lining that you lose, which wouldn't count towards your blood flow. There can also be mucus, another thing admixed with the blood. But my general rule of thumb is certainly if you feel like you're having to change your pad or tampon frequently, certainly if you're feeling like you have to use 2 products at the same time, so I'll often have women who say, I'm soaking through like a tampon and a pad at the same time, that's a red light, we shouldn't have that much bleeding. Or if you can't go through a night without soaking something, that's something to come and talk to your doctor about. Really, the causes for this type of bleeding are very similar to everything we went through before with frequent periods. So again, your evaluation is going to be your history exam, same kind of lab studies, making sure that other things like your thyroid isn't off. With you having this heavy bleeding, checking to see your blood counts with your CBC to make sure you're not anemic. If we think that there's any infections going on, testing for that. And then again, doing your imaging and potentially, again, doing a biopsy if we think that there could be abnormal cells causing this very heavy bleeding for you. So again, treatments are similar to everything we just went through. If we think some other external source is causing your heavy bleeding, we might recommend, again, you change your hormonal contraception method, treat your thyroid. The surgical managements, we just went through all of those for the uterine polyps, cervical polyps, and fibroids also could be causing your heavy periods, so all those treatments would basically be the same. So now let's talk about actually missing periods, which this is one that I feel some women might not be too worried about because, hey, if you can avoid having a period, great. But it is actually something that should be evaluated and that you should bring to the attention of your doctor because it can be a sign even of other systemic things that are going on. So like we talked about, the normal cycle length can be anywhere from 21 to 35 days. So if your cycles are more than 35 days in between them, that is the medical term to describe it as oligomenorrhea, or you're missing periods, essentially. Now, there is a difference between, of course, missing periods and not having periods. The medical term for having no periods is amenorrhea. So just to talk about that briefly, primary amenorrhea means that by the age of 15 years old, a girl hasn't had her period yet, and that is something that should be evaluated. So I do get that question from some moms sometimes, is it okay that my daughter hasn't had her period yet? She's, 11 or 12. Yes, until the age of 15, we'd consider it normal, but then certainly after that, we need to look a little further and see if there's something else going on. Secondary amenorrhea can occur when you have been menstruating. So if you have had regular periods for all your life, we give you 3 months of having no periods before we would call it secondary amenorrhea. Whereas some women do have more irregular periods throughout their life, and if that's the case for you, then if it's been 6 months, again, we would consider you to fall into secondary amenorrhea. And certainly, if your periods have fallen away, again, that's another something that should kind of set off some alarm bells for you, and you should bring it to your doctor's attention. But I kind of thought of this topic really in relation to PCOS or polycystic ovarian syndrome, because that's something that I hear women asking about all the time in the office, and that is probably one of the most frequent causes of infrequent periods or missing periods. There certainly can be other causes, so that's not the only thing we're gonna evaluate you for if you come in with this concern. Hyperprolactinemia, or high levels of prolactin, which is a hormone that your pituitary gives off, can also cause you to miss periods. Again, thyroid disease, the thyroid can really mess with everything, so we check that frequently. Primary ovarian failure is also known as early menopause. This is when your periods stop before age 40. Sometimes the first sign of this can be your cycle's really spreading out, and that is definitely something that we would evaluate for by, again, checking that FSH hormone level to see if you're menopausal at that point or not. And then sometimes there can be actual structural causes too. If you had surgeries of your uterus before, there could be concern that you had adhesions inside the uterus that were actually not allowing your periods to come. So that's something else that we would evaluate for. But again, evaluation, no surprise, we're gonna get a history, find out how long this has been going on, and all the specifics. We're gonna do an exam. This is one that a lot of times we do rely a lot more on our laboratory studies to do some evaluation for. And then again, imaging to take a look at structural causes. I put the criteria on here specifically for PCOS, because again, I feel this is something that many women hear about, and then if they're having irregularities with their periods, wonder if that's what's going on. Despite its name being polycystic ovarian syndrome, the ultrasound is not the only diagnostic criteria for PCOS. It really is more of a clinical condition, and we most commonly use this Rotterdam criteria, where there are 3 categories, and if you meet any 2 of those, that would be considered diagnostic for PCOS. So it's possible that you could have an ultrasound with completely normal appearing ovaries, but if you met the other 2 categories, could still be considered to have PCOS. Those other categories being signs of hyperandrogenism. So the androgen hormones are the male type hormones or testosterone. We can determine this both clinically or through labs, so we can actually test your testosterone levels. But some women will come in complaining of excessive hair growth and male pattern. I have to, wax my chin every 2 weeks, way more than all my friends are, or I have very cystic acne. Things like that can be signs of higher testosterone levels that could lead us to think that you fall under this category. And then again, the menstrual irregularities. So with PCOS, again, it's your periods spreading out, so you might be skipping periods for months at a time. That makes us think PCOS as opposed to periods that are more frequently coming together. But again, this is something that we don't want you to ignore. Sometimes, like I said, it might be like, hey, great, I don't have to deal with this bleeding every month. But a lot of these, like for example, PCOS or primary ovarian failure, early menopause, can have significant clinical impact on other systems in your body. So for example, PCOS is really considered to be a metabolic state. It can increase your risk for obesity, for elevated cholesterol levels, for diabetes. So there are other things that this could be a trigger for us to make sure that your overall health is looking okay, not just the fact that you're not having periods. With primary ovarian failure, women who have lost their periods before the age of 40, we become very concerned about your body being exposed to such a low estrogen state for that many years. So for those women, it's actually definitely recommended you get on some hormone replacement. Low estrogen levels too early in life can lead to early osteoporosis, which is thinning of the bones, which can lead to very high risk for fracture. It can also lead to early cardiac disease and early dementia. So all of these things, the period really is considered one of the vital signs for women, and if you're missing it, that's definitely something that you should let us know about. So the treatments I brought up here were, again, specific to PCOS, because I do hear a lot of these concerns in the office. So, we think about how we're going to treat PCOS kind of based on where women are at in their life. Obviously, if you're considering pursuing pregnancy, the treatment is going to be different than if you were actively trying to get pregnant. So women not pursuing pregnancy, combined oral contraceptives are considered to be the first-line therapy for PCOS. They help decrease that metabolic syndrome that's going on and kind of regulate your hormones a little bit better. Metformin has also been shown to decrease insulin resistance and help regulate periods. And for women having those significant hyperandrogen issues like the acne or the hair growth, sometimes they'll go on anti-androgen therapies. You might have heard of spironolactone as a common medication used for that. With those specifically, it should be noted that those would be considered teratogenic or should definitely not be used with a pregnancy. So usually if you're on a medication like spironolactone, you should also be on some sort of reliable birth control to make sure you don't get pregnant while on that medication. Women pursuing their pregnancy, of course, we're not going to put you on birth control because you're trying to get pregnant. But that can be another issue with PCOS, is that it can make getting pregnant more difficult. There are certain ways that we can help with that also. Like I mentioned, PCOS does increase your risk of obesity, which does also impact your fertility levels. Studies have shown that losing just 5 to 10% of your body weight that it is at currently, whatever that is, can significantly increase your fertility. Metformin has also been shown to specifically increase fertility for women with PCOS. And then a lot of times the actual fertility issue for women with PCOS is that they're not ovulating. So you're having bleeding even when you do have a period, but your ovary is not kicking out an egg. So sometimes we use the ovulation induction medications. And then of course, sometimes you can even go on to other assisted reproductive techniques with REI. Some women have also had success with alternative therapies like acupuncture too. So there are definitely, again, things that we can do to help, and things that, like I said, you want to keep in mind for your overall health, that really if you're missing periods, there are things we should address. So now we'll get a little bit away from bleeding issues and talk about just painful periods, which this hopefully is something that you wouldn't shy away from bringing up, because who wants to be dealing with this every month? So again, it can be a sudden onset, which might lead us to think about more emergent causes versus something that's been going on for a long time or becoming worse over time. So again, there can be a lot of causes for painful periods. I tried to break it up into what would be considered emergent. So this would be a significant sharp onset in pain that a lot of times is going to take you to the ER, should take you to the ER. And that can be things like ovarian torsion, ectopic pregnancy, or abscesses in the pelvis. Some things that we can deal with more chronically over time are endometriosis, which is where the outside or the glands of the inside of the uterus, endometrium, can grow basically anywhere outside the uterus where we wouldn't expect them. So for example, on bowel, on your bladder, on your ovaries, on your fallopian tubes. What this does is then every month when you're having your period, that tissue, not just inside your uterus, but that has spread to everywhere, gets inflamed and angry and causes significant pain with periods. We actually don't know exactly what causes endometriosis. There's several theories on that, but no one knows for sure. Adenomyosis is where instead of the glands of the uterus spreading outside the uterus, they tend to grow into the uterus, where it's actually the glands of the uterus are growing into the muscle, which causes intense pain with cramping, because again, those glands with your periods are getting inflamed right into the muscular layer of the uterus, causing much more significant uterine inflammation and almost contraction-like pain. Fibroids can cause significant pain, which might come on all of a sudden or grow over time. Ovarian cysts can also be obviously irritating inside the pelvis, cause pressure or pain-like symptoms. Infection can cause pain. There can be other causes that aren't necessarily your female organs. Like I like to say, the uterus and ovaries and fallopian tubes are the only things that are in a female pelvis. There's also the bladder, so the bladder issues, and bowel. So different changes in your bowel movements could also be causing painful pelvis. So again, no surprise, we're gonna do a thorough history, kind of get the character of the pain, where it is, timing of the pain, throughout the month. Is it all the time? Is it only on your period, only before your period, after your period? All these things can kind of help give us a general idea or direction of where we might think that our diagnosis is going. Again, doing a thorough exam. Depending on the history or what we're suspecting, there might be different labs that we want to do. And then again, imaging, either a pelvic ultrasound or an MRI to look for those structural causes I was talking about, like fibroids, ovarian cysts, things like that. So treatments, again, are medical, surgical, and alternative. Things that can be treated medically do include endometriosis. Suppressing your cycles with hormonal contraception is a lot of times how we initially go ahead and try to treat endometriosis. The only way to actually definitively diagnose endometriosis is surgically, but to do that, we need to do a surgery inside your belly, find an endometriosis lesion, take it out, and send it to the pathologist for them to identify under the microscope. For a lot of women who are having painful periods who we might suspect this, we're not necessarily going to say, you need to go to the OR and have a surgery just to figure this out. We can, a lot of times, diagnose endometriosis clinically, meaning that if we suspect that you have endometriosis and we suppress your periods and that successfully alleviates your pain, then a lot of times that's considered a clinical diagnosis of endometriosis. Adenomyosis, again, has no way to definitively diagnose it other than when your uterus is removed with a hysterectomy and examined under the microscope, and it is shown that the inside lining of the uterus has grown into the muscular layer of the uterus. No one's going to do that just to diagnose it. We would try to treat medically, again, by suppressing your cycle, and if we can decrease that inflammation with your cycle and your pain is relieved, then we are considered to think there might be an element of endometriosis with your pain. Fibroids and ovarian cysts, same thing. If we can suppress your cycle and that helps, then medical therapies can be definitely beneficial. For ovarian cysts specifically, once we know that you have a cyst, putting you on a hormonal contraception is not going to treat the current cyst that you have, but different contraceptives work in different ways, and the ones that suppress your ovulation, so they keep the ovaries from ovulating, are ones that are going to be helpful to prevent future ovarian cysts. So if we know, for example, that you had a large cyst that ruptured and caused a lot of pain, we might talk to you about getting on a hormonal contraception to prevent that from happening again in the future. So again, they're not going to make the current cyst shrink. A lot of times cysts do resolve on their own, although sometimes we do have to go in surgically and remove them, but they can prevent you from having future cysts. Certainly in a case of ovarian torsion, which is considered an emergency, that has to go to the OR right away. That is when your ovary has twisted on its own blood supply, effectively cutting off the blood supply to your ovary. So the pain you're feeling is actually from the ovary dying, for lack of a better word, and we don't like having dead or necrotic tissue inside of us. We definitely feel that as pain. So this, again, is that acute kind of emergent pain that I was talking about. An ovarian torsion would be an acute onset of severe pain to the point that I usually describe, like you're doubled over. It might be associated with significant nausea and vomiting just from the amount of pain. You're not able to go about your daily activities. This is the kind of pain that's going to take you to the OR or to the ER to get evaluated. They'll do an emergent ultrasound, and on ultrasound, one of the things we can also look at is the blood flow to the ovary, and if the blood flow is absent, that would be a sign of an ovarian torsion, which then could be surgically corrected. A lot of times we can flip the ovary back and return it to normal blood flow, and you don't have to lose the ovary, ideally. An ectopic pregnancy, so a pregnancy that's growing outside the uterus, would certainly cause pain if it got to a size that it was causing what most commonly is growing. It is the fallopian tube, and if the fallopian tube was getting to the point that it was breaking open or bleeding, that would cause a severe onset of pain, similar to the kind of pain I was describing for ovarian torsion. So that would also be something that would take you to the ER. You'd most likely be getting emergent evaluation and taken to the OR for that. Tubo-ovarian abscess is essentially an infection inside the pelvis. It's walled itself off in the form of an abscess. This sometimes will present itself as severe acute pain, as I was describing for torsion and ectopic pregnancy. Sometimes it can also be kind of a febrile illness that slowly grows and just isn't controlled by your typical, I'll take some Tylenol for a few days and rest, but you seem to be getting sicker and sicker. And then eventually come in for evaluation, and we find this on imaging. So this is something that typically is actually treated medically first. When we find an active tubo-ovarian abscess and a patient is acutely ill, we treat with IV antibiotics before we consider going in to an infected pelvis to do any kind of surgery. But then sometimes if the abscess has walled itself off and is not resolving on its own, then we do have to treat surgically. And then, of course, endometriosis can be treated surgically. Sometimes medical management is simply not enough. Sometimes we are wondering more about the diagnosis, and so we'll go ahead and do what's called a diagnostic laparoscopy. So we stick a camera through the belly button and take a look in the pelvis and are looking to confirm our diagnosis and actually remove endometriosis implants, which for a lot of women, if there is significant implants throughout the pelvis, if we are able to remove them, remove any scar tissue they may have formed, or a specific type of ovarian cyst can also be associated with endometriosis called endometriomas, which can grow quite large in size and also be painful. We can remove those surgically and hopefully give some relief of pain. Adenomyosis, again, ultimately, like I said, would have to be a hysterectomy in order to take care of that condition. But certainly, painful periods also can be addressed with alternative treatments. Again, some women have success with acupuncture, and different pelvic floor therapy treatments can also be helpful. So other things can be explored as well. So now we've gotten to number 6, so the big mystery, vulvar itching. That was our surprise one that kind of dropped off the front. But so moving away from periods, now we'll kind of talk about other things that should also draw your attention and cause you to come in for evaluation. So really having itching on the outside of the genital area for women can seem to be benign and annoying, but really a lot of the times, first of all, it's something we can really help with and significantly relieve symptoms. I've seen some women who will tell me they've been applying over-the-counter creams up to twice a day for years just because it took care of the itching and they didn't think to do anything else about it. But if we take care of the problem, can save you from having to do all that for so long. So definitely something to bring to our attention. And then also it can be a sign of some more serious conditions, like this vulvar intraepithelial neoplasia, or VIN, which is really precancerous cells. And then of course you can also get cancer of the vulva. So itching, burning, dryness, discharge that's really persistent is something that you should mention to your gynecologist so that we can look into it further. Again, history, exam, labs. And then I did do this order of things specifically. Sometimes we will actually try a treatment and then do a biopsy. So some of the skin conditions that I mentioned here before, like specifically lichen sclerosis or lichen planus, psoriasis, they can have very specific physical exam characteristics. So we might look and say, you know what, I think I know what this is, so let's try this treatment for a few weeks and see if it improves. Because the ultimate answer, if we don't know, is to do a biopsy. And no woman gets excited when you tell her that we need to take a piece of the skin from your outer genital area and take a look at it under the microscope. It's not the most comfortable thing. So sometimes we will first try a treatment, and if the treatment is successful, we know that the skin condition we suspected is being treated, and we can leave it at that. Sometimes if we're just not sure based on the exam, or if the initial therapy isn't helping, then we're definitely going to recommend a biopsy, which, like I said, I know no woman is going to look forward to, but it is a very small, usually 3 to 5 millimeter, what we call a punch biopsy. That's this instrument here, that we will give you lidocaine for this biopsy procedure. So basically, you get a quick numbing injection, which unfortunately is a little bit the smallest needle we can use, and then a little bit of a stinging. And then after that, really the biopsy part you won't feel. You know someone is touching you and that you're having an exam, but you shouldn't feel anything sharp. So the worst part of it is the numbing procedure. But again, certainly if it's something that has been refractory to treatment, so it's not responding, or something that to us looks like definitely needs further evaluation, then we're gonna do a biopsy to be able to have a sample to send to the pathologist to figure out exactly what's going on. So treatments, I kind of mentioned, a lot of the skin conditions, we can try a topical steroid. Sometimes if we think that the itching or discomfort is really from vaginal atrophy, like I mentioned earlier in talking about menopause, the treatment for that is a vaginal estrogen therapy. Of course, if there's some specific infection going on, we're gonna recommend the treatment for that. Sometimes if very abnormal cells are identified, like that VIN or vulvar cancer, of course the recommendation is going to be for excision of those cells. And then continued monitoring. Some of the conditions, certainly if you have any history of the precancerous cells, we're going to want you to be coming in regularly to make sure that that doesn't happen in a different area if it's removed from one spot. Once we know that you've had it, you're at an increased risk of having it again. So we'd want to do certainly annual exams, sometimes more frequently. But even, for example, lichen sclerosis is a chronic skin condition, but we know that that puts you at a slightly increased risk for different types of skin cancers. So you should definitely be making sure to come in for your exams to continue to have your pelvic exam every year and make sure that nothing else is going on. So then we can talk about pain with intercourse. I kind of tried to break this up into the different phases of women's lives because there can be different causes based on where you're at. So premenopausal painful intercourse, again, it can be sudden onset versus chronic. There can be a lot of factors that go into painful intercourse. Sometimes it is anatomic, sometimes there can be history of abuse or stress that can add factors into that also. So some of the anatomic causes that we think about, ovarian cysts can be causing a deep kind of pain with intercourse. Endometriosis can certainly be causing pain with intercourse, or if there was pelvic organ prolapse, tissues in the vagina that were dropping, that can be causing pain with intercourse. There can also be medical conditions. Of course, infection can make the tissues more irritated. Vulvodynia is a chronic pain syndrome, one of those that, again, we don't have a perfect answer for or know exactly why it happens. It's thought it could be nerve endings that have been overly sensitized or kind of fire too quickly. There's some thought that it can involve the pelvic floor musculature, actually causing frequent spasms, but that is a medical condition that can be causing painful intercourse. And then actually hormonal contraception. I do have some women come to me who are very frustrated, feel like they've been worked up for everything. Everything's always coming back negative. And really, any kind of hormonal contraception can cause increased vaginal dryness or pain with intercourse. And sometimes if that's really the only thing left that we have to try, we'll try taking them off that hormone and doing a non-hormonal contraception, like an IUD. There's the new Phexi gel you can insert, or condoms, things like that, but just to test to see if the hormonal contraception was actually the cause of the increased pain. So evaluation, again, no surprises here. We're going to talk to you about how long it's been going on, when this all started, if there are any specific positions that cause the pain, if there's a particular part of intercourse that seems to be more painful, whether it's initial penetration or deep penetration. Doing our exam can certainly give us some insight if we certainly see lesions or signs of an infection, or can reproduce your pain, might give us a better idea of how to treat things. And then, of course, any studies, if we think that there's there's infection going on, test for that. If we sometimes think that it is an actual skin condition, some of the things that I was mentioning with the vulvar itching, like lichen sclerosis or lichen planus, could certainly be causing pain with intercourse also. So if we're expecting or suspecting a dermatologic condition, we could do a biopsy. And if we think it might be something actually going on deep inside the pelvis, like an ovarian cyst that's causing your pain, we can certainly do imaging like an ultrasound to evaluate for that. So again, treatments, of course, are going to be based on what we think the cause is going to be. Ovarian cysts, like we talked about, we can't necessarily cure a cyst that you have other than surgically removing it if we need to, if it's of a large enough size. But we can suppress the ovaries from ovulating to prevent future cyst formation. Endometriosis, all the treatments we just discussed in going over painful periods, if we can kind of get your endometriosis under control. Typically, if it's causing pain with intercourse, there may be implants that are specifically at the top of the rectum or in the vagina that are causing some of your discomfort, or there could be large cysts, as I talked about, the endometriomas that could be causing some discomfort with intercourse, so going after those specific treatments can help with that. Vulvodynia, the chronic pain I was mentioning, can be treated really in a lot of different ways. PFT is pelvic floor therapy. So like I mentioned, some of the thought with vulvodynia is that it might have to do with the actual pelvic floor muscles and them being in a constant state of contracture and not something that you are consciously doing or trying to contract, but that's just kind of their baseline. Pelvic floor therapy can sometimes help with relaxation of those muscles. Also, if there was any element of the introitus or entry into the vagina being contractured or small, sometimes use of dilators can help with that with pelvic floor therapy. There are certified sex therapists, which we do have some clinics here in Boulder that you can go to that can help tackling kind of the nerve ending issue that I was talking about with vulvodynia. Topical lidocaine or a numbing cream on the outside of the vagina can help. If we think estrogen therapy can also help, just adding that little extra hormone to those very sensitive vaginal mucosal tissues. And then a small dose of tricyclic antidepressants, the medication that was around for years, obviously for depression, has also been shown to be helpful for vulvodynia. So that's also another method that can be tried, and I've had good success with that. Of course, with infection, obviously we're going to treat whatever the infection is. Like I said too, sometimes we kind of get to our end of the rope, and if nothing else seems to be the cause, we'll try to remove the hormonal contraception. I find that most commonly either Depo-Provera or birth control pills are the culprit when it comes to hormonal contraception and painful intercourse. Typically it's caused from those particular birth controls kind of drying out the vagina and leading to less lubrication. So again, switching to a non-hormonal method such as Paragard, which is the copper IUD, can help us tease out if that was what was going on if you were using either of those methods. And then, of course, if we identified some specific anatomic cause, like a large ovary that was causing pain, surgically we could remove that. We talked about how we can treat endometriosis surgically, and pelvic organ prolapse. So if there was the uterus coming down into the vagina, making the vagina smaller or more difficult to have intercourse, or bladder prolapse or rectal prolapse, all of those things can be treated surgically as well. And then, of course, alternative therapies, acupuncture again, seeing sex therapists, also some women have great success with that. So again, postmenopausally, you can have different types of painful intercourse caused from different things. So atrophy, we kind of talked about with the beginning slide of the postmenopausal bleeding. Infection or vulvodynia can also occur postmenopausally. And then pelvic organ prolapse tends to be more common postmenopausally, so I just brought it up here as well. But really very similar causes. Evaluation, you're used to me hearing now: history, exam, labs, biopsy, occasionally imaging. And therapies really are very similar. The one big difference I'd bring up is the procedural vaginal laser therapy treatments. We mentioned that again with the postmenopausal bleeding, and that can be those Mona Lisa Diva lasers that help increase the collagen in the vagina and strengthen those tissues, and can help also with pain with intercourse if that's the issue. So you can also have abnormal lesions. You should be looking and you should be feeling. That's really the big takeaway from here. So some women, you might not feel that you need to be looking down there, but especially if you're not getting your annual gyne exam, which hopefully everyone watching this is seeing their gynecologist every year for a full exam, just know that you should also be looking and feeling occasionally. And if you, just similar to how we tell you to do your self-breast exam every month at home, you should also be taking a look, feeling when you're showering or bathing, and if something seems different than what's normal, you should let us know. There's lots of, evaluation again is going to be history, exam, labs, and biopsy. There can be a huge differential for this, so I just put some of the most common things up here. Not common, but things you might not think of. The biggest one I wanted to highlight was melanoma. Not many people realize you can get skin cancer of the vulva or vagina, but you absolutely can, so another reason to continue getting your annual gyne exams. Treatments, of course, are as varied as the diagnosis. So the big thing here is just don't be shy, bring it up if you think that there's something weird going on down there. And then lastly, I just kind of wanted to talk about ovarian cancer. Truthfully, there aren't a lot of symptoms. Ovarian cancer is known as the silent killer because typically there are no symptoms until advanced stages of the disease. But this is one of the questions that I would say I get multiple times a day in the office, so I wanted to bring it up in this lecture somehow. So certainly family history can be some indication if you need to have specific genetic screening done, if someone in your family has had ovarian cancer, or if there are multiple relatives with breast cancer. But if we're talking about symptoms specifically, if women are going to complain of symptoms, the most commonly mentioned symptoms are bloating, an increasing pant size, and not just like my pants are a little tight, but women with ovarian cancer will have found that they literally need different size pants in just a few months' time with not necessarily a lot of weight gain. And then difficulty eating or feeling like you're filling up really quickly, so you just can't get in a full meal anymore. Certainly abdominal or pelvic pain, and then again, that increased abdominal size. So noting that your pant size is going up quite quickly. If there are going to be symptoms, most commonly, these are the ones that women can present with. So again, the evaluation, you're used to me saying now history, exam, imaging. A lot of women will come in and say they want the laboratory screening test for ovarian cancer. Most commonly what you're referring to is CA-125. The truth of this lab is that it was actually developed to be a marker during treatment for ovarian cancer of how women are responding to treatment. The problem with the reason it's not used as a screening test is because unfortunately it's rather nonspecific in women who don't have known ovarian cancer. So if I just picked Jane random off the street and tested a CA-125, it could actually be elevated for reasons beyond ovarian cancer like endometriosis, pulmonary issues. It's kind of a non-specific marker when we don't have known ovarian cancer. So we don't particularly love to do it as a screening test just because, like I said, it can be very non-specific. So a lot of times, unfortunately, the truth is there isn't a great screening test. It's most important to just know what the risk factors are and what can increase your risk of ovarian cancer. So that would be things, like I said, of having a family history, certainly anyone with ovarian cancer in and of itself, but also multiple relatives with breast cancer or colon cancer are also a flag to us. Certainly if you have genetic testing done and we know that you're BRCA1 or 2 positive, but any of the reasons that would make us want to test you, which would be any of the cancers that I just mentioned in your family history or history yourself of being an Ashkenazi Jewish heritage, that would make us want to get some genetic testing done. Being postmenopausal or over 40 years of age also increases your risk for ovarian cancer. So kind of knowing some of the factors that can increase your risk can help us in doing an evaluation, and then ultimately doing a pelvic ultrasound to get a look at the ovaries. Certainly there are certain types of lesions of the ovary that can look more suspicious than others and would make us do further evaluation. So of course, if we do diagnose or have a strong suspicion of ovarian cancer, there's going to be a referral to a gynecologic oncologist, and treatment is usually a combination of medical and surgical, meaning chemotherapy and radiation type treatments, as well as surgical. So thank you for joining me tonight. Hopefully you're more awake than my puppy was here at the end of all of this. And if you'd like to schedule an appointment, there's the phone number for my office.
We've come to the end of our time. A recording of tonight's lecture is available at bch.org/livestream. You will receive a post-lecture survey by email. Please take a minute to fill this out. Again, please visit bch.org for information on COVID-19 vaccination. Thank you for joining us, and have a good night.